So good afternoon to everyone. I hope everyone had good workshops and a good lunch break. And right now we are at the panel entitled Healthcare Access as a Human Right. And you will hear introductions to our wonderful panelists from our equally wonderful moderator, our colleague and friend here at JTS, Rabbi Dr. Naomi Kalish, who is the director of the Center for Pastoral Education and assistant professor of pastoral education here at JTS.
Thank you and good afternoon. After working as a hospital chaplain for 20 years, it's been my great joy to have come back to JTS, my alma mater, in order to oversee our educational programs, introducing students to healthcare settings, as well as to the counseling aspects of religious leadership. Something that struck me so much at this convening, as well as in my work in healthcare, has been the ways in which we sometimes address what we could call the most universal of human experiences. We've been talking about healthcare this afternoon. We've been talking about food scarcity. We've been talking about clothing and housing needs. And perhaps we could say that these are the most universal of human experiences. Throughout time and place, people have responded to these different aspects of human experience, and I'm thinking especially of the experiences of illness, of injury, of hospitalization, of the dying process, of death, and of bereavement. And throughout time and space, different cultures and religions have responded in various different ways through storytelling, through developing traditions and mechanisms for caring for people, and also by asking existential questions, questions that sometimes are asked broadly and sometimes very personally, like, why did this happen to me? Is there a connection between my behavior and my misfortune? What happens later? Will I see and be reunited with the people I love? Sometimes this sense of shared humanity leaves us to make statements like, disease does not discriminate. We heard this a lot during the pandemic, especially the beginning of the pandemic. This consciousness of shared humanity can lead us sometimes to think that social boundaries dissolve. But what we've tragically seen over and over again is that when we've recreated or created new systems for caring, a whole new social structure emerges. And within that structure, boundaries and barriers do not dissolve. Perhaps new ones have emerged. We have a panel today who bring us a wide variety from an interdisciplinary perspective, a wide variety of approaches for us thinking about healthcare access as a human right. I was going to give some brief snippets of introduction to each of our panelists, but would actually like to leave it broadly as they each bring a variety of different perspectives, from theoretical, textual, personal, and sometimes clinical wisdom to our conversation. We will hear in this order Dr. Diana Romero, who will bring to us a public health and sociologist perspective. We'll hear from Dr. Paul Wolpe from a Jewish bioethics perspective, Rabbi Shmuly Yanklowitz from a religious and activist perspective, and then finally we'll hear from Dr. Amanda Alladin from a clinical and healthcare ethics perspective. After they speak, we will then open up for questions. You can start thinking now. We will collect several questions at once and then pose those questions to our panel. So without further ado, Dr. Romero.
Thank you very much, and I'm super excited to be here today. As a public health researcher, the concept of health as a human right seems obvious, at least to me and my colleagues. Yet we live in a country where that statement is contested intellectually and definitely not evident in healthcare practice. That is, we don't all have access to healthcare in this country, nor is it evident in health statistics. That is, disparities in health status and outcomes are widespread. That's pretty much the meat and potatoes of public health work. But in the United States, is not the world, and we can look to many sources of support for this notion of health as a human right. So I'd like to talk a bit about the historical international context of the right to health in general, and then to reproductive health, which is my particular area of research focus. I'll then review where the US stands in terms of access to reproductive health care in light of recent changes in abortion policy specifically, and wrap up with some findings from recent research that we've conducted with physicians who are trying to provide care to pregnant patients. So to start, there's a fairly long international history of declarations stating or suggestive of health as a human right. I'll just mention two really essential ones. The World Health Organization Constitution in 1948 advanced this definition: health is a state of complete physical, mental, and social well-being, and not merely the absence of disease. I quote, "The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being without distinction of race, religion, political belief, economic, or social condition." And that has underpinned the work of the World Health Organization to this day. Secondly, the UN Universal Declaration of Human Rights of the same year, 1948, stated, "Everyone has the right to a standard of living adequate for the health and well-being of themselves, and of their family, including food, clothing, housing, and medical care." Similarly, when we consider specifically reproductive health, there are several international consensus documents that we can also turn to. I'll just highlight two critical ones as well. In 1994, the International Conference on Population and Development, or ICPD, Program of Action took place in Cairo. It was the first time an international consensus document stated that, quote, "reproductive rights are human rights," and set out reproductive health care as part of states' obligations. Governments agreed to provide, quote, "universal access to reproductive health care" by 2015. We're not quite there yet, but that was a goal. A year later, the Beijing Declaration and Platform for Action, which was the Fourth World Conference on Women, reaffirmed that women's human rights include reproductive rights and commits governments to action on women's health. Among its 38 statements was one specifically, I'll quote, "the explicit recognition and reaffirmation of the right of all women to control all aspects of their health, in particular their own fertility, and that is basic to their empowerment." Now, these population and development conferences built on prior international conferences, which I won't go into in detail, but asserting the importance of, if not the right to health, as a main driver of both individual fulfillment and national progress or development. Essentially, that it's good for people and for countries. But then there's a difference between signing on to international statements and what actually happens on the ground, particularly, as we focus on the United States. And when it comes to reproductive health and the supposed, right to health care. Before I get to the US picture on the ground, I think it's helpful to remember that abortion care is health care, and several professional health and medical associations have made explicit statements to that effect. Firstly, my professional organization, the American Public Health Association, in 2010 issued a policy on protecting abortion coverage and health reform. It stated that APHA considers the availability of safe, legal, and affordable abortion care to be essential for safeguarding maternal health, reducing maternal mortality and morbidity, and enabling healthy spacing of pregnancies. 5 years later, in 2015, APHA released a statement saying that, quote, "restricted access to abortion violates human rights, precludes reproductive justice, and demands public health intervention." If we move into the medical space from the public health space, the American College of Obstetricians and Gynecologists issued an abortion policy statement also in 2015 that, quote, "It supports every person's right to decide whether to have children and the number and spacing. Individuals seeking abortion must be afforded privacy, dignity, respect, and support, and should be able to make their medical decisions without undue interference by outside parties." Only last year, the American Medical Association issued a position statement that it, quote, "supports patients' access to full spectrum of reproductive health care options, including abortion and contraception, as a right. A physician's ethical obligations is to help patients choose the optimal course of treatment through shared decision-making, et cetera." And I'll return to this point in particular. And then the American Academy of Family Physicians also issued a statement just this year supporting access to comprehensive pregnancy and reproductive health services, including but not limited to abortion, contraception, surgical, non-surgical management of ectopic pregnancy, and opposes non-evidence-based restrictions on medical care. The AAFP believes pregnancy and reproductive health services are essential to general health care and should be covered under all insurance plans. So multiple medical associations and public health associations supporting reproductive health care, and specifically abortion care, as a human right, and anyway, I'll leave it there. So despite these international declarations and U.S. public health and medical society policy statements, current U.S. policy essentially denies health as a human right and has acted very intentionally to restrict, if not remove, access to reproductive health care, and certainly most aggressively with regard to abortion care. The 2022, only 3 years ago, Dobbs Supreme Court decision overturned the long-standing precedent of Roe v. Wade, such that access to abortion is no longer protected by the federal government, but rather left to individual states. Now, just 8 days before the Dobbs decision, so when Roe was still in place, there were 33 states that provided access to abortion without restriction. It was essentially a medical decision, and there were no total bans in any state on abortion. Today, 3 years post the Dobbs decision, 12 states have a total abortion ban, and 29 states have abortion bans at various stages of gestational duration. Only 9 states, compared to 33 3 years ago, but only 9 states in the District of Columbia do not restrict abortion on the basis of gestational duration. So given this new reality, states without total abortion bans, like New York, where we are, experienced a 26% increase in abortions provided in 2023 compared to 2020, when Roe was still in place. So what impacts have we seen in these 3 short years? And I'm talking about clinical impacts. Well, there's essentially limited or no right of access to health care that specifically affects pregnant people and their families in many states across this country. Compared to states where abortion is accessible, states that have banned or have otherwise restricted abortion have, and hear this, fewer maternity care providers, because many physicians have left those states, more maternity care deserts for similar reasons, higher rates of maternal mortality and infant death, especially among women of color, and higher overall death rates for women of reproductive age. Pregnancy essentially should not be associated with death, but we've seen increases, substantial increases in states that have banned abortion care. Mothers living in states that banned abortion care are nearly 2 times, or rather pregnant women, are nearly 2 times as likely to die during pregnancy, childbirth, or soon thereafter, compared to women living in states where it is not banned, where it is legal and accessible. And while maternal mortality fell 21% in states that are supportive of abortion care, like New York, maternal mortality rose 56% solely in the state of Texas in the first full year of that state's abortion ban. Black mothers living in banned states were over 3 times as likely to die as white mothers in those states. So certainly a racial disparity. And that's not the end. There's certainly more to come. These are early days. So in addition to the impact on patients, denying the right to reproductive health care also impacts doctors. Over the past year or so, we have carried out a project called the Medical Integrity Initiative, interviewing physicians in 4 abortion-banned states. Some were OBGYNs, but there were also many doctors in other specialties, such as emergency medicine, cancer specialists, geneticists, family medicine, fertility specialists. Not surprisingly, pregnant patients may have pre-existing chronic health conditions like chronic kidney disease, high blood pressure, diabetes, but they may also be diagnosed with health conditions when they are pregnant or experience medical emergencies, right? They may be diagnosed with cancer, with gestational diabetes, have an ectopic pregnancy, maybe be involved in a traumatic accident, and therefore need a doctor, not necessarily an OBGYN, but a different specialty. Thus, doctors other than OBGYNs often have to care for pregnant patients, many of whom may be intentionally pregnant. That is, they want to carry that pregnancy to term. However, treating women's medical issues may not allow for continuation of the pregnancy. Now, prior to the Dobbs Supreme Court decision, this may not have been a problem in most parts of the state, where a pregnant person with a health condition may have been treated as part of the standard medical care. But the landscape is very different today. Our findings from interviews with physicians as part of this project have highlighted a wide range of obstacles to doctors being able to provide life-saving standard of medical care in states where abortion is restricted, if not banned. I'll briefly summarize the 4 main findings and then wrap up. First, physicians described a loss in their decision-making authority and confidence in independently making treatment decisions. For example, they might now reach out to another doctor just so that they have, support, so they're not being charged with making a bad decision or wrong, illegal decision on their own. To quote one, "It just feels like you're not empowered to make decisions that you know you should be making for your patients in the timeline that you used to make them." Number 2, physicians are forced to compromise quality of care when all medical options aren't permitted. For example, intentionally denying, or rather delaying standard care, or referring when they didn't used to. So to quote another physician, "You always just worry when you feel like your hands are tied and all available medical procedures aren't available for the patient in front of you as they used to be." 3, physicians feel unable to support their patients due to legal constraints on their provision of care. Some have said they felt like they were abandoning their patients. Quoting this physician, "I want to continue an open and therapeutic relationship with our patients. I'm trying to navigate this in a way that stays true to the reality of the situation and also stays true to patients." So when this was impossible, they described it as a, quote, "painful for them and certainly painful for their patients." And finally, some participants engaged in what we called acts of resistance to uphold their integrity as physicians, oftentimes at the risk of their jobs, maybe fear of losing their medical licenses, being financially, if not criminally, charged for providing care. And to quote this individual, they said, "Some people are going to let the woman be near death's door with sepsis before they do the termination. And other people are going to say, well, her water broke, it's 18 weeks, 17 weeks, and she's got a little bit of tenderness. I'm going to go ahead and do it." And every time that person makes either decision, they're just challenging someone to come arrest them. So it's probably no surprise that in addition to the very difficult position physicians are in trying to care for patients, that we document the clear indications of their experiencing moral injury. That is, an injury to an individual's moral conscience and values resulting from an act of perceived moral transgression on the part of themselves or others that produce profound feelings of guilt or shame. I can certainly go on, but to sum up, the impact of abortion bans, essentially the denial of the right to health and health care, is most directly on pregnant people and their families, with serious consequences for their health and lives that have already become evident from some of the data that I shared with you. Yet I think the corresponding impact on doctors and other healthcare providers who are committed to healthcare as a human right, but are increasingly unable to provide it, is much less recognized and an important part of the equation. Thank you.
Yes.
So I had a talk planned for today. I was going to start with a critique of the idea of dignity that is common in bioethics, that the term is vague, that it's analytically useless. It's simply a placeholder for other ethical principles like autonomy and justice that are more easily measured and defined. I was going to tell you that from this perspective, dignity is a inconsistently defined word. It's used in many different ways. It lacks clear criteria for when it's violated and can obscure rather than clarify arguments. I was going to suggest some of the solutions that people offer, either better to drop the term at all, to specify its more exact constituent principles like autonomy and justice, suggest dignity isn't a single thing but a multidimensional concept. Then I was going to drive it all home by pointing out that Hebrew agrees with this critique because there is no word for dignity in Hebrew. The word that we use, kavod, means honor, respect, even glory, as well as weight or heaviness, as in when we say heavy responsibility. So if Hebrew doesn't need a word for dignity, do we? And then I was going to try to explain why I think we do and what the term adds and helps us with. And that's what I was going to talk about. And all of that changed on Thursday. I was in Abu Dhabi, United Arab Emirates, for a conference, and Thursday night I was lying in bed and I felt a pain in my stomach. It was a very sharp pain in the lower left quadrant of my stomach, and I'm lying there saying, okay, what do I do now? I'm in a foreign country. Am I going to lie here and try to tolerate this all night? Is it time to call a doctor? I went back and forth and back and forth. I'm at a conference. It's called Dialogue. It's an invitation-only conference. It's for high-level tech executives. Certain politicians go to it. UN representatives go. It's a very high-level tech-oriented conference. And then they invite a few other people just to leaven it like me. They figured, oh, having an ethicist there might be fun. So I get to go to these conferences where, for the vast majority of people there, my net worth is a rounding error of their paperclip budget. And I'm lying there and I send a message to the Dialogue staff saying, I need a doctor. I hear a knock on my room, and I know all the staff. I've been to 13 of these conferences. I know everybody. And in my room comes Kristen. She's maybe 26, 27 years old, wonderful, sweet person. They hire only the best. And she's very concerned. She says, I called a doctor, should be here soon. I just came to sit with you. Pretty soon there's a knock on the door. The doctor comes in. He's with a nurse. They're carrying 2 drag bags. And I'm out of it. And I say, oh, are you staying at the hotel? And they laugh like I've just made a great joke. Good, because I did make a joke. In those bags were IVs and poles. They set up an IV pole. They put a Tylenol drip into my arm. And she takes out a blood test, and they start catering to me. And I've worked in medical schools my whole life, but I'm not a doctor. Therefore, I know exactly enough medicine to misdiagnose myself constantly. So I say, I think it's diverticulitis. And he goes, could be a kidney stone. Now, I have had kidney stones in the past, 3 times. Pain was always in my back. So I said, through my medical wisdom, but the pain is in my stomach. He says, could be a kidney stone. So after a while, he says to me, you need to go to the hospital. The last thing in the world I wanted to do was go to the hospital in the United Arab Emirates. And Kristen said to him, okay, well, how do we do that? He goes, well, I can call an ambulance. And Kristen, who's now become my caretaker, said, well, how much will an ambulance cost? And he looked at her like she was out of her mind. He goes, nothing. An ambulance doesn't cost anything. She goes, okay. And he said, now, which hospital do you want to go to, the government hospital or the private hospital? And she said, what's the difference? He goes, well, there's a lot more issues dealing with, like, money and things at private hospitals. She goes, well, which gives better care? And he looked at her again like she was crazy. And he said, they both give the same care. And so Kristen decided that I was going to the government hospital. Ambulance came, two wonderful men came up. Everybody speaks English in the UAE. Came up and they were just lovely. They took me down in a wheelchair, which was wonderful at a conference to see your colleagues. Hi. Went into the ambulance. Kristen is in the ambulance with me, and she says, I have to plug in my phone's running out of power. He goes, oh, pick any USB. It's just, there's medical instrumentation anywhere, everywhere. He says, pick any USB and plug it in, it'll charge it. So she's sitting there charging her phone in the ambulance as we get to the hospital. At the hospital, the nurses, the doctors, everybody is just absolutely wonderful. And they say, we need to give you a CAT scan. And I look at Kristen, she looks at me, and I say, oh boy, I wonder if my insurance is going to cover all this. And they're about to roll me into my room, and they say, but you have to register. And Kristen says, and he says, what will he need to register? It's just his passport. Chris says, give me the passport, I'll register for you. Kristen goes and registers, and she comes back, and she said, they asked me if I was your wife, and I said yes. Just one little problem. I already have a wife of over 40 years. Now, I had visited the Emirates house. You could do many different activities there that the conference arranged. One was visiting what they called the Emirate House, which was this house that they set up to look like how people lived 100 years ago there. You sat on the ground, and they brought us food, and they talked about life, and you could ask questions. And we talked about the fact that in the UAE, you can have up to 4 wives. So I figured this is okay. She'll be wife number 2. Nobody seemed to be at the slightest bit concerned that I was 68 and she was maybe 26. That seemed to be fine with them. My wife actually thought it was quite humorous. They took me to the CAT stand. That took maybe 5 minutes. Took me out, stuck me in the CAT stand, brought me back. Kidney stone. And they told me that, it would pass, that they would give me pain management. They prescribed 5 drugs. We went down to the emergency room pharmacy, Kristen taking charge of everything. She has sat with me. I've been there all night. Kristen has been by my side all night. And then we check out, and Kristen is taking care of everything. And she says to them, how does he pay for this? She says, with a credit card. So I hand her a credit card, and we look at each other and go, 5 drugs? Yeah, I wonder how much this is going to be. The bill came in, $69.50. And that was all I paid. As we're leaving, Kristen says, well, maybe they'll bill you. And I said, how are they going to bill me? They never asked my address. They never asked my phone number. All they have is a copy of my passport. They can't bill me if they wanted to. It was all free care. So, by the way, Kristen is getting, don't tell her, but she's getting a lovely bouquet of flowers for Thanksgiving. She was absolutely wonderful and took care of me the whole time. I'm feeling a little better the next day. I get to do some of the things at this conference that I went to. I missed a lot of the conference. I'm not feeling completely better, but the pain is gone. And I say, I'm going to fly home. My flight from Abu Dhabi to Amsterdam is okay. I have a 2-hour layover. I get on the flight from Amsterdam to New York, to JFK. About an hour into the flight, I say, uh-oh. And all of a sudden, I start to get the kidney stone pain. That moment was a terrible moment. Let me tell you, I don't know how many of you have had kidney stones or know people who've had kidney stones. They say it's one of the worst pains you can have. It is. The last place you want to have a kidney stone attack is on an airplane. And I'm saying, I'm in big trouble. So I wait, and it starts and it happens, and it gets worse. Not the worst kidney stone pain I've had, but just really bad. And I go to one of the flight attendants. I said, who is the flight attendant in charge? She says, Karen. I go up to Karen. I say, Karen, I'm having a kidney stone attack. I'm in really great pain. I need a place, is there a place I could lie down, a place away? She says, yes. She takes me to the back of the plane. There are 3 seats there. She goes, lie down on these seats. I lie down, and then this flight attendant, Tara, comes by. And Tara says, I hear you're having a kidney stone attack. She said, yes. She goes, oh, that's terrible. Let me know if there's anything I can do. About 10, so I'm there just writhing. I took Tylenol, and she comes back and she goes, okay, this is Tara. I'll get fired if you ever tell anyone this, but I have a Percocet in my purse. She says, do you want it? And I said, I don't want you to get fired. She goes, well, just don't tell anyone. So I said, yeah, that would be great. That Percocet is what got me back home. And in fact, another thing happened. Another flight attendant who hadn't heard this came and she goes, you can't lie here. This is just for flight attendants to sit in when we're not working. I said, talk to Karen. She had given me the flight attendants' seats to lie down in. Then I get to JFK, go right to my hotel, put everything down, and walk over to Mount Sinai. I go to Mount Sinai, and I say, I'm having a kidney stone attack. I ended up spending 9 hours at Mount Sinai on Sunday night, where nurse after nurse came into that room with care and concern. Now, why do I tell this story? I was asked to talk about the dignity of healthcare access. In Pirkei Avot, it tells us, who is honored? One who honors others. Dignity isn't sort of an ontological status that you possess. It's something enacted in relationship. But I thought, don't we also think of dignity as somehow inherent in us? It's not just in relationship, but it's something that we are. We are dignified being. Then how can it only act or exist in relationship? And I thought about that a lot as I thought over the last couple of days about changing this talk and telling you this story. And then I realized in a strange way, dignity is like the Jewish idea of Shabbat. How is dignity like Shabbat? So a question that you might ask in the Jewish view of Shabbat, remember the central place Shabbat plays in Jewish life, very different than Sabbath plays in Christian life. And a question that Jews could ask, is Shabbat inherent in the nature of the world, or do human beings bring Shabbat into being through its observance? And of course the answer is both. Shabbat is inherent because it was part of God's creation of the world. God rested on the seventh day from all that God had created. And the act of resting instantiates that day into the rest of the fabric of creation. It's like a rest in a piece of music. That's not separate from the music. It's part of the music. In fact, Miles Davis once said, music is what happens between the notes. Yet even though it's built into creation, it has no meaning for human beings in our lived experience if we do not manifest it for ourselves. And it's the same with dignity. Do humans have innate dignity? Yes, they do. It's inherent in the structure of being human, like Shabbat is inherent in the structure of creation. But again, like Shabbat, the important question isn't whether it's there. The question is, will we act in ways that bring dignity into being, that manifest dignity for all? And as Emmanuel Levinas points out, healthcare access isn't about affirming pre-existing dignity.
That's my apologies.
Yeah. It's about creating the conditions where dignity can be mutually recognized and where it can be enacted. And healthcare access is one powerful way we answer yes. We will enact it that way. In US, dignity was offered to me despite a system that mitigates against dignity. I'm a sociologist by training. I studied healthcare access as a graduate student, and all of the study of healthcare access is the way in which, in the United States, access is denied in various ways of people who need it. The dignity that was given to me at Mount Sinai was the choice of the people who offered it to me. It was dignity in interaction. Now, I'm fully aware of the privilege that puts me in a position to attract that kind of treatment. But in the UAE, Dignity is designed into the system. There's dignity offered there because healthcare is designed to warrant it. It's free. It treats each patient like they are worthy of getting the best kind of care. Now, that's easy to do in an incredibly rich, incredibly small country. I'm not overestimating why it is that UAE has such care. But it is possible to design that into our system as well. So in the end, we do need the word dignity. Yes, it encompasses all those definable aspects that we talked about, autonomy, justice, and respects, but it also exceeds them because there's an independent quality of the human presence, the indescribable connection of Levinas's encounter of the other. I experienced it over and over this weekend by many different people in many different places, and for that I am grateful.
I want to thank Rabbi Tucker and Dr. Newman and Rabbi Kalish and Ellie and Eli and all of the great leaders of this very fine institution. It's a great honor to be here with you for this conference. I like to talk through text studies, so I do have a text coming around. And while that's coming around, I'll share a few other ideas. Elie Wiesel, whose yahrzeit we just commemorated, wrote in his famous Nobel Prize acceptance speech, "That's why I swore never to be silent whenever and wherever human beings endure suffering and humiliation. We must always take sides. Neutrality helps the oppressor, never the victim. Silence encourages the tormentor, never the tormented. Sometimes we must interfere when human lives are endangered, when human dignity is in jeopardy. National borders and sensitivities become irrelevant. Wherever men or women are persecuted because of their race, religion, or political views, that place must, at that moment, become the entire center of the universe." So I ask the question, what are we willing to do for human dignity? What are we willing to put in jeopardy? The Talmud says we should jump into a hot furnace before even shaming a person. You know, in the famous case of Le Chambon, the Protestant village in France during the Vichy Nazi puppet government, they had declared great danger if you housed a Jew. And Pastor Tragme stood at his bima, and declared their city an Ir HaMiklat, a city of refuge. Well, pastors, clergy love to declare things, but only shortly after, Madame Tragme got a knock on the door, and there was a large Jewish family outside the door. And she saw that it was cold and rainy, and she said, "You must be so tired. You must be so hungry." Looking at her children, knowing what was at stake, to open the door. And she let them in. And after the war, when their family and their village would save thousands of Jews, was asked, why were you willing to do that, to sacrifice your families, to sacrifice everything? They didn't quote abstract philosophers, nothing against them, but they quoted simple scripture and their belief in dignity in a way that animated their life. Now, one of my greatest rabbis, Mother Teresa, what I loved about her was that she changed what it meant to be a nun. You don't just daven Tehillim all day. You don't just pray psalms. You go out into the streets and you find people dying in the streets and in the dumpsters. And she was in Calcutta, as usual, finding people in the dumpsters, and she found a woman dying, and she said, "Why don't you let go?" And she said, "I can't let go because I'm so angry at my sons who left me here." And she told her to take a deep breath and to forgive them. And she forgave them, and she passed. And I think about that story not only to the barriers to dying, but also to the barriers to living, and the barriers that we have towards taking the risks necessary to defend human dignity. So let me share a little bit of where I'm coming from today, in a little bit of our work. First, we operate humanitarian buses. We're working with unsheltered people around the streets who are struggling to find any healthcare support and other resources. They lack the transportation, the funds, the trust in the system, and basic access. We have a shower project working with asylum seekers who don't even want to go to the ER because of fear that they don't want to be in the system, and they will get deported. Not to mention the inadequate healthcare provided in immigrant detention centers. Let me share one snippet of what that can look like for a person. In the case of Daniel Cortez, he was in dirty immigration cells, being mocked by guards for his weight, denied his epilepsy medication, and he tried to hang himself. He was on suicide watch, and that meant they put him in solitary confinement where he fought off biting ants and endured black mold on the wall and feces in his cell. They kept the lights on 24 hours a day, which aggravated his seizure condition. He attempted suicide 4 more times. The legal director of the facility there in my state said, "I worked in detention centers around in Arizona for nearly 15 years, and I'm not aware of a single client who received what I would call counseling on mental health." He voluntarily, 2 years ago, accepted deportation to Colombia. In our work with foster children, we're seeing enormous needs that they have. We're over 500,000 kids in the system each year, about 600 to 7,000. Most of all those foster youth who age out of the system lose support and end up in the pipeline to homelessness, to prison, or to trafficking. From the prison reform side, we're thinking about those who aren't getting proper health and mental health care while incarcerated, often can't access the meds they need. They can, of course, be beaten and shamed and without having any legal protections that are exercised. As someone who has spent many occasions serving in villages in the global south, thinking about the devastating cuts in US aid, not only vaccines, but other medical care, as someone involved in kidney donation issues, for example, my wife just donated her kidney to a stranger a year ago, there is a need for legislation to support. According to Donate Life America, 5,600 people in the US who die each year on the transplant waiting list. More controversially, I've argued that we should open the market and compensate donors. Thinking about factory farming and our American diet so reliant on animal products of meat, fish, eggs, dairy, and how much suffering is involved for animals, but also how much suffering is involved as the #1 cause of death in America being heart disease, and how crucial preventative health and nutrition is for education as well, not to mention COVID and its relationship to its origins in animal cruelty. I'm also thinking about technology and the threats that the AI world poses to us as we move forward being subcognitive and lacking more critical thinking skills. Also around the conversations of transhumanism, do we really want to put chips in our brain to alter our humanity? And if so, which would make us more healthy as individuals and a society, and which would perpetuate illness? So I was going to first tell you my arguments for healthcare as a human right, because health is necessary for all other freedoms, because human dignity requires protection from preventable suffering, because illness can't be treated as a market transaction, because healthcare equality supports opportunity and mobility, because public health depends on population-wide access being interconnected, because human worth cannot be based on wealth. But a right is not just once one needs surgery. It's also preventative health care, and to live in a healthy society with healthy food, less fear and anxiety, having the means to rest. But I'm not here to suggest that Judaism guarantees rights of healthcare rights, but rather to stimulate our moral imagination for health at large. So here I turn you to the text that I passed out from Avot de Rabbi Natan. You might have to share if there weren't enough. It's an Agadic work, probably published in the Gaonic period, 700 to 900 Common Era, and I love this text, and it's the first time I've taught it, or shared it really, I don't have time to teach it. Rabbi Eliezer, the son of Rabbi Yossi HaGalili, would say, HaKadosh Baruch Hu, in God's wisdom and insight, created the whole world with the heavens and earth above and below. And here's the key line, V'yatzar be'adam kol ma shebara be'olamo, that God fashioned within the human being everything that God created in the world, right? There's a mirror, there's a parallel. The way Rabbi Nachman talks about this, he says, every conflict in the world exists as an inner conflict within the human being. If we could resolve the conflicts within the self, we could resolve it externally. For the Kabbalists and in monism, all reality is ultimately composed of a singular fundamental substance. For Rav Kook, as a mystic, he looks at the relationship between the part and the whole. If we're sick, the world is sick. Working on the individual health level, we're working on the collective level. It's interconnected. So I'm going to run through a few of these. I'm going to run through these examples quickly, just because I find them fascinating. in the rabbinic imagination of what was created in the world and how that has a parallel human body part. God created forests and God created hair. God created evil beasts in the world and intestines. God created thorns and ears, scent in the world and scent in human beings, their noses, sun in the world, and created a person's light. This reminds me of the famous Mishnah in Sanhedrin, to save a life is to save a world. Again, the micro and the macro. The putrid waters and the water that drips from humans' noses. Salty waters and tears in their eyes. Here I'm thinking of Buber, how on the macro level, peace or justice begins on the micro level of human encounters, of the teary eyes. I'm thinking of the connection between droughts and dehydration, rivers and human yearning for water. Walls and lips, doors and teeth, skies and a person's tongue, sweet waters and spit, chiseled stones and jaws. We go to the back. Towers and a human's neck, sail yards and a person's arms, spikes and fingers, a king and his head. The head reminds us of Levinas, who argued the entire moral structure of society in the macro emerges from the face-to-face in the micro. Clusters in the world and blood, advisors in the world and kidneys, right? The Talmud understands kidneys as a Yetzer Tov and Yetzer Hara, so if you donate one, make sure to give the right one. Millstones in the world and stomachs, grinding mills and spleens, garbage heaps and bowels, pits and navel, running water and urine, going back to the miracle of kidneys and the miracle of rain, life in the world and blood. Here I think that of the possibility that the cure for humanity can be found within one animal species, trees and bones, hills and buttocks. And here I think of a person sitting on a hill or a mountain and zooming out, and from a far distance you can't see the person on the mountain because they are only one. From the zoomed out perspective, the micro merges. From the macro perspective, the micro merges together into that one. Mortars and knees, horses and thighs. I'm speeding up a little bit here. Angel of death and the heels. Think of Yaakov and Esav. Think of the Achilles heel. Mountains and valleys, and when people stand and they fall. And then we end. Halamarta shechoma shebara kadosh baruch hu ba'olamo bara ba'adam. Everything that Kadosh Baruch Hu created in the world was created within every human being. There's a mirror of the self in the world, the health of the individual and the health of the world. Some medieval Jewish thinkers describe humans as olam katan, a small world whose inner life mirrors the structure of creation. In Lurianic Kabbalah, each mitzvah in the micro repairs cosmic fractures created at the dawn of creation. So, we often talk about society as if it were a distant entity. An abstract force that acts upon us, shapes us, constrains us, sometimes uplifts us, and sometimes leaves us bewildered. And we talk about individuals as if each of us were fully autonomous, free-floating beings responsible for the entirety of our choices and the trajectories of our lives. But the truth, as philosophy, sociology, psychology, and even biology teach us, is that the micro and the macro are inseparable. They're constantly interacting, constantly shaping one another, like two dancers who cannot move without influencing the other's step. Some were taught that the only real change is systemic. We need advocacy and change on policy. We need changes on all levels of individuals, families, communities, and not just national and global. We need healthcare on local and immediate and humanitarian levels, village by village. Yes, we need that systemic change, and the Torah asks more of us to see everything as part of health, our teeth and our rivers, our thighs and our skies, all aspects of society and our life. And it would be too simple to merely suggest we should advocate with politicians for systemic reform, even as we saw a government shutdown being around the Affordable Care Act and how much is at stake for people. But I close this with saying that what we need is not just to advocate, but actually to inspire a new moral imagination for empathy, to see our interconnected health, the state of our health on an interconnected level. Because a study done out of the University of Michigan just a few decades ago showed that the capacity for empathy in America has dropped 40%. dropped 40%. If I'm a man, it's harder to know what it's like to be a woman. If I'm white, what it's like to be a person of color. If I'm straight, what it's like to be queer. If I'm rich, what it's like to live in poverty. If I have a body with abilities, what it's like to live with a body of different abilities. If I'm currently healthy, what it's like to live with illness. It's harder and harder for us to imagine. And what I want to suggest is that that is the central Jewish work, is to re-inspire the empathy for what it's like to ultimately live with illness, and to not just see this as the job of government, but to see this as the part of families and communities and everyone in society to care for each limb and each mental state, ultimately seeing how the micro and macro are interconnected. Thank you so much.
Good afternoon, everyone. Today I'm going to just share a little with you guys about some of the challenges we face at the bedside in the pediatric intensive care unit regarding access to healthcare as well as dignity and humanity. So I'll start by just describing two cases very briefly. Of course, the details are anonymized to protect the patient's privacy. But we have TW, who has been through multiple transplants before the age of 6 and lives in a single-parent household, facing significant housing, financial, and transportation barriers. And therefore, TW has significant difficulties adhering to the complicated post-transplant management. We also have SA, who was previously healthy, but also because of SA's parents' financial and transportation difficulties, does not go to preventative healthcare visits. SA is doing well until SA has a severe respiratory illness and has a cardiac arrest event at home. SA survives the hospitalization, but can no longer breathe for himself, eat for himself, and therefore, to be discharged, will need a ventilator, a tracheostomy, and tube feeds through the stomach. SA's parents cannot support him like this at home. Even if they got the 24-hour nursing care they needed, one of SA's parents would have to be there 24/7 with the nurses at home, and their finances just do not accommodate this. So I bring up these two cases to show that these children are now going to live a lifetime of medical complexity with a high burden of healthcare needs. They're going to have a completely disrupted family life, and the burdens of their disease as well as the technology that supports them are going to mean that they're in and out of the hospital constantly. And the reason this is important is because medical complexity is increasing in pediatrics. So depending on the definition you use, up to 30% of children in the United States may have a chronic condition, and a smaller subset of these patients will have a chronic complex condition. And earlier estimates of this were put at about 10%, but I'm sure that number is higher now. And the reason that we want to focus on these children, it sounds like a small number, but these children with chronic complex conditions actually account for a quarter of hospital bed days and 40% of hospital charges and in-hospital deaths. So this is a vulnerable group. We also see that in robust studies, PICU utilization is increasing. So we see that the kids are presenting sicker to the ICU with more organ failure, with more comorbidities, and more children are utilizing some form of technologic support when they get admitted to the ICU. At the same time that we see complexity increasing, we see that access to pediatric care is actually decreasing in the United States. So these are all summaries of the studies on the left-hand side. But in a survey of the American Hospital Association, more than 4,400 hospitals in the United States, 77% of these hospitals have limited to none in terms of pediatric services. And from the 10 years between 2008 to 2018, almost a quarter of children in the United States had an increase in distance to their nearest pediatric inpatient unit. So these are pediatric beds and units that are in community hospitals, that are embedded within adult hospitals, and due to low staffing or low volumes or reimbursement or for whatever reasons, these beds and units are closing. And this disproportionately impacts children in rural areas because the specialized pediatric hospitals are the ones that are gonna do well and stay open. And what about access to pediatric subspecialty care? In almost 11 pediatric specialties, there's one or fewer physicians per 100,000 children in the US. So we see that depending on where you live, right, where you live in the US and what degree of medical complexity you have or what your personal barriers are to healthcare, you may not be able to access pediatric inpatient units or pediatric subspecialty care. But there's also a huge disparity in how neighborhoods in the United States support child health and development. So the group that has done this work, diversitydatakids.org, they've developed something called the Child Opportunity Index, and this is more than 20 years of research that they've put into this. So the Child Opportunity Index is a complex marker of 44 neighborhood indices that describe how well neighborhoods support child health and development. And what they found is that children in the United States grow up in 5 different Americas. So if you look at the map, the lighter areas are areas that have very low child opportunity index, and the darker areas, the dark blue areas, are very high opportunity index. And there's a range in between. And this group has shown what we know to be true intuitively, that Black, non-Hispanic children and Hispanic or Latino children of all races are more likely to live in low or very low COI areas. So it just highlights the geographic and the racial disparity. So what are the health risks to children living in low and very low COI areas? These children are more at risk of preterm birth, of chronic diseases such as asthma and obesity, of ER revisits and PICU admissions. These children are at higher risk of death, and they're also at higher risk of losing a parent or a caregiver because the violent death rate, the crude violent death rate increases as the COI decreases. These children are less likely to be up to date with their preventative health measures. And despite having a higher burden of healthcare needs, less health expenditure is spent on children in low COI areas compared to high COI areas. So how does this filter down to the bedside? We have this geographic disparity, we have these racial disparities, and this gets even more complex at the bedside. So we have LD, who is in organ failure and needs to be listed for transplant. LD is a US citizen, she's insured, but her parent is undocumented, and this parent is terrified of the family being separated or of being deported. So the parent does not consent to transplant. And we are now left at the bedside in this exquisitely difficult situation. What do? We are ethically obligated when a parent declines a life-saving therapy for a child to consider, is it appropriate to override parental authority? So in this case, do we seek a court order to approve LD for transplant? Or if we suspect some form of neglect, do we report them to Child Protective Services? Both of which are going to expose this family to what we know is a potentially cruel and destructive process. Or do we accept that this is an impossible choice for this family? But accepting that means that LG will die without a transplant. And this creates so much moral distress for teams at the bedside because it's almost an artificially created barrier, right? There's no reason LD can't access a transplant in terms of insurance or citizenship or any of that. But for social reasons, this becomes a big problem. And we also have a patient like SB, who has migrated through multiple countries on a months-long arduous journey with her parents and crossed the United States by bus and landed in Miami, and heaven knows what scenarios she was placed in, what her nutrition was like, what she was exposed to during that trip, but she lands in our ICU in severe multi-organ failure. And she needs the highest level of technologic support that we can institute. And we pour months of work into SB. We try everything we know. We put her on the heart-lung machine, and despite everything, SB dies. And we were asking ourselves each day, are we doing the right thing for SB? Not because she wasn't insured, not because she was undocumented. We still tried everything in our power to help save her life. But her family was so traumatized and struggling with the most basic of needs. They didn't have money to take the bus to come to the hospital. They didn't have clothes. They didn't have somewhere to live. And we were here superimposing this extreme medical complexity on top of a family that is so stretched. So each day we would ask ourselves, as SB had more and more complications and the chances of her surviving were smaller and smaller, we asked ourselves, is it right to keep going? Because should SB survive, she may end up in a circumstance like one of our first patients I described in the first scene, where she needs a tracheostomy, a ventilator, home nursing, and she's not going to be able to access any of that in this country. So it really creates a lot of distress and challenges at the bedside. So in summary, I just wanted to highlight, I know this is obviously a huge topic, but there are a lot of distributive, social, and racial justice concerns when it comes to access to pediatric healthcare right here in this country. And at the bedside, resource utilization and allocation becomes really challenging because we have so much technological advancement and we don't have the corresponding social support. How do we reintegrate these children with critical and chronic illness back into their communities and back to their homes? We put so much into saving them, into transplanting them, but what awaits them when they go back home? And we don't talk about dignity in pediatrics so much as we talk about it in adults, and typically it's in adult and hospice and palliative medicine that we talk about dignity. But dignity is absolutely applicable to pediatrics. If you think of dignity as agency, communication, respect, patient and family-centered care, that is absolutely a pediatric bedrock. So we should be exploring the concept of dignity in pediatrics more. And to close, I just want to say thank you to all of the amazing advocates and speakers, and to JTS and Dr. Newman and Rabbi Tucker for focusing on such an important topic, because it can feel really hopeless at the bedside sometimes, very discouraging, and we feel powerless to be able to do what's right for the patient in front of us. But I have been really fortified by all the talks and by the amazing work that all of you are doing. It's really important. Everything you do helps us take care of these patients and families, and helps us do our work. So thank you all for everything you're doing. I just want to briefly introduce you to my hero, who is Dr. G. Patricia Cantwell. So she's the Jamie Lee Curtis looking blonde lady in these pictures. And she was a commander in the Navy. She's been our division chief for the past 25 years of pediatric critical care, and she's the Florida Task Force 2 medical director, urban search and rescue. So those pictures on the bottom right are her deployed to ground zero after 9/11. So she's just an incredible individual, but out of her sheer moral and ethical compass, she has created and sustained a pediatric palliative care service at our institution with nothing, with no financial support, no support for her time. And all of these pictures you see are experiences that she's created for children in our hospital, because she firmly believes that children deserve to have normal childhood experiences, even if they have chronic and critical illness and then they're in hospital for months. So we've had weddings in the hospital, we've had graduations in the hospital. We can't take the kids out because maybe they're too sick, maybe we don't have the funds to support, taking them on field trips, but we take them to the helipad of our trauma center. We ask all our first responders and the flight crew to show them the chopper. We ask our Miami police mounted unit to bring the horses for the kids, because they enjoy all of these experiences. So it's a lot of doing what you can with what you have where you are. And Dr. Cantwell has taught me, when you can't control all of these factors that are occurring out of your sphere of influence, be relentless in taking care of the patient in front of you. You can always take excellent care of that patient and family and use all your resources, however scrappy or minimal they might be. Utilize everything you can to take good care of that patient. So thank you for your time and attention.
Thank you. Such amazing and rich perspectives from each person. We have a little under 10 minutes to take some questions, and as I said before, we'd like to take several at the same time. As people are writing their questions or indicating they'd like to ask a question, do any of the panelists want to, is there anything you'd like to respond to that you've heard from one another? Or we can go directly to the audience if we have questions. So you can just keep that in mind as the questions come in. Well, why don't I ask a couple questions? So one question I have, given that the panel operated on many different levels. We had direct clinical levels, personal, professional, theoretical. I'm curious what advice you'd give for steps that people who are here today or who are watching, how they can engage on any of these levels, or also how they can cope with the fact that there's I heard a certain kind of distress, both in the clinical or the personal that's upfront and personal, or just the challenges of working on the policy level and the social level, and that takes time. So what advice would you give for people as we're all navigating health and healthcare in some capacity in our lives?
So I've been in healthcare for 40 years as a bioethicist in the clinic and in teaching. And I have rarely ever heard someone come up to me and say, all of my healthcare experiences have been fabulous. Without exception, doctors have been kind, the healthcare system has worked, the insurance companies have been responsive. It's just terrific to get sick in this country. I heard nothing but complaints, with an occasional, that wasn't a bad experience. Which is why I wanted to tell a story that said, at every stage of my experience of the last week, people were kind, the system was responsive, people were doing the best they could. But what I was thinking as I had a lot of time to think in 2 different hospitals, lying there for 9 hours. And when I was in UAE, I was thinking, everybody is treated exactly the way I'm being treated right now in UAE. When I was lying at Mount Sinai, I thought, not everybody is treated the way I'm being treated here at Mount Sinai Hospital in New York. And I think that that's the difference, and that's what we do. We should always, we're very preoccupied with our own treatment, our own illness, and those around us. But if we look downhill, if we look to those less fortunate than us, we see that all of our complaints are trivial compared to their complaints. All the ways we are treated are trivial. Yeah, I had to wait for 40 minutes on the phone with my insurance person to get this covered. Yeah, but you got it covered. I think we need to have a lot more appreciation and sympathy and awareness of people that don't have the privileges that many of us, I'm not presupposing everybody in the room has those privileges, but, and that's where the work has to be done. The work has to be done in trying to make healthcare access equitable in this country, because it isn't.
Some thoughts that come to mind for me, I think I was really interested in the analogies from Rabbi Shmuly and some of the work that I do in terms of the macro and the micro. And I think, maybe building just on what you said here, we oftentimes default to what our personal experiences are, and I think just pushing ourselves to think about what, beyond that, what the sort of landscape looks like, maybe among other people in our environment, this issue of inequities and disparities, but also just some of the data that I pulled up to show how access to healthcare in particular contexts is different in different parts of the country, very directly related to policies. And I think oftentimes we can default, especially in something as politicized as access to reproductive health care in this country, which is not new, right? But the fact that that particular aspect is very politicized, I think we might default into the arguments and positions that are defined by politics. And if we take a sort of a step aside and just look at, okay, what are these policies resulting in? And maybe it's not, folks should have the right to this or the right to that, but identifying that in different contexts, the outcomes and experiences are different, that people may be sicker, they may be dying, they may have to travel further, they may not be able to access care because they have to travel further. And I think maybe just reminding ourselves that the really contentious political language might not be serving us very well, but pointing to what the different experiences are in different places in the sort of macro picture, not just ourselves, might be a way forward.
Picking up on your last point, just briefly, first, I think there are those who view political sparring as fun and all technology as fun, but these two factors, the political toxicity and unrestrained technologies, are creating major challenges for stability and dignity and mental health of youth. Second point is that we should be prepared in the streets, whether it's with food or resources of where people can call or where they can go, or Narcan for people who have overdosed, that there are asylees who are living in the shadows, afraid to come out, and unsheltered people, and with cuts to basic social services, there's going to be increased number. So in addition to the system, the people who are outside of the system be prepared on a daily basis for how to support them.
I think where my mind goes when you ask, like, what can people do? I've been really fixated with this Child Opportunity Index research, and we all see it in the metropolitan areas, right? There are very, very high opportunity areas right next to very, very low opportunity areas. And I think this research is driving us in the direction, like, if we can improve neighborhoods, we can improve children's health and their adult outcomes, and that's the work that you're all doing already, but you don't necessarily directly connect it to health all the time, but having green spaces in a neighborhood for children to play, making neighborhoods safer, having better teachers recruited to a particular school in a neighborhood, all of these are really important things. As we heard this morning, improving the education of girls and women lifts a community. Improving the neighborhood conditions will improve health for everyone in that community. So it's a direct link, and I think you guys are already all working in those spheres.
Thank you. I think we have a question.
I have a question. Thank you for each of the panel members. Can you explain intrinsic unconscious and extrinsic bias and how that interferes with the delivery of care from individual providers and health systems?
Do we have a panelist who'd like to respond?
Intrinsic consciousness, say it again.
Intrinsic unconscious bias and extrinsic bias, and how that interferes from the individual provider and the health system interfering with quality of care.
So I'm not so sure in this amount of time we can go into deep explanation of it, but what I will say that it's certainly a big concern in medical care and in public health that there is oftentimes what we call structural bias or systemic bias, which is this, I think, more intrinsic, unconscious. I'm not a clinician, but certainly a lot of research has been done to show that clinical decision-making and recommendations based on the profile of a patient that may have nothing to do with the individual clinician's, explicit biases. Maybe they don't even have, any that are meaningful, but that training has been such that you look at the data, you see that people of particular characteristics are more or less likely to have certain, health outcomes and be more or less responsive to treatment. They may be more likely to or less likely to be provided with certain treatments. And that has been, pushed back with a movement toward more patient-centered care. So I think there's probably a very legitimate case to be made for the more explicit biases, but the sort of greater concern is what's been built into systems, and different interventions have been undertaken, like training or retraining of healthcare professionals, or the way systems work to mitigate that. But I think it still is very much present.
And on that note, medicine and research has perpetuated this, intrinsic bias, because we've attributed a lot of things to race and ethnicity without delving deeper into people's social determinants of health. And we're seeing like a real shift, I think, in research currently, that it's not about race and ethnicity. It's not that one race experiences something differently, because these are all social constructs, right? But it's what's underlying, like the neighborhoods, like the pollution, like their access to healthcare. So I think there's a lot of work being done to improve this underlying bias that has been perpetuated in research.
So we are just about at our time boundary. Maybe we can take one more question, just briefly.
Yeah, first of all, I want to thank you. What an amazing panel to get a different perspective on so many different ways on the same issue. Thank you. I want to just lift up and bring a name and bring into this space something that unfortunately is incredibly politically tied, but that is always forgotten when it comes to healthcare. On the map that you put up of all the deserts, all the white areas I instantly saw are all of the native reservations are white. I grew up in one of them. It's in South Dakota. It's got the lowest density, the lowest help, the lowest health care. And I just want to bring into this space the fact that Indian Health Service, as it is called, was given as health care was considered a right and was given as treaty rights to Native people in this country and has never, ever been completely funded well. And that Native health care and the amount dedicated to it is less money than is spent on people in prison to this day. And that every statistic, I always hear about it in terms of Black populations, Hispanic, et cetera, all the statistics are extremely worse for Native Americans, for Indigenous people in this country. Yeah. And so I just wanted to bring that into this space.
Thank you for sharing that important point. So just as a concluding comment, the discussion today reminded me of a point I always found very meaningful in the statement of core values when I worked at New York Presbyterian Hospital. In addition to saying that they valued excellence in healthcare and research and quality, they also included empathy. And the reason why they included empathy was, I think we've heard stated by each of our panelists, that both the what of healthcare as well as the how of healthcare makes a significant difference. And research has been conducted showing correlations with actual healthcare outcomes as well as benefit to neighborhood and the stability of the healthcare institution, as well as intrinsically the value in and of itself of being, we heard it over and over, engaged with by people, Dr. Wolpe, you referred to Levinas and the encounter of the other and this, you said, intangible sense of presence or, being able to have the inner life. I'm thinking of Dr. Alladin, like you were talking about people's experience of feeling terrified, going through the healthcare experience. And Rabbi Yanklowitz, you talked about this inner experience that people have in the macro, micro kind of connections. And we heard Dr. Romero about the moral distress of healthcare workers. So it's not only the what that they are providing, or not providing, but the experience that leaves our healthcare team with. So I think that's one of our takeaways that we can be grateful to each of you, is both for helping us understand better how to advocate and support the access of healthcare, as well as the how people experience the healthcare system. Thank you, everyone.